Yeah, so I wanted to just maybe give a couple of minutes for participants to join, so that then we can just start the session. But for now, I'll just welcome all the panelists to the session. I know that we are going to have quite a rich discussion on this particular subject. To start us off is to just give a bit of an overview of what this session is all about. From the agenda that was shared, is about efficient data management, and we will be talking about the role of JeMPI in the Kenya's National Data Warehouse. Lined up today, we have panelists that are a rich panel that's constituted by Ministry of Health representatives, Lily Nyaga, who is the Strategic Information Lead at the National AIDS and STI Control Program. We have panelists from JeMPI, who have been participating in design and development of the MPI solution, but also its integration with the National Data Warehouse in Kenya. We have the team from Palladium, who maintain Kenya's National Data Warehouse, but are also part of the team that developed the solution. So the session is structured in that we will have two presentations to start off the session, after which then we will have panel discussions that will provide and attend to different aspects of the developed solution and its value proposition to public health programming for HIV control, epidemic control in Kenya. So to start us off, I'll just talk a bit of a brief background. We know that many countries are shifting to individual level data systems. While this solves several challenges that countries have encountered with the paper-based systems, it also presents new challenges of unique person identification. So patient identity management becomes a very important subject that needs to be discussed. So to start us off, I want to give this chance to Paul to take us through a brief presentation about Kenya's National Data Warehouse and the challenges that we have been facing and how then this ties up with the patient identity management solution. Paul is a software engineer within Palladium. She's a senior software developer, and will be taking us through the first presentation. And then we'll hand over to Natasha, who is a senior business analyst within JeMPI Health Systems, and will be taking us through the second part of the presentation, which will be focusing more on the MPI solution. So I'll give it over to Paul to take us through the first presentation. Paul, over to you.
Thank you very much, Dr. Jacob. I believe, as he's just mentioned, I'll be giving you an overview of our National Data Warehouse and a brief on how we manage to integrate JeMPI into the platform. Okay, so I'll start with the background on our National Data Warehouse. So with support from the CDC and Kenya's Ministry of Health, Palladium manages a National Data Warehouse, which records 91% of ART clients. The warehouse sources data from over 2,200 facilities, aggregate data sources, and mHealth systems. Individual level data on persons living with HIV in the National Data Repository has allowed Kenya to conduct case level validation and triangulation of service statistics reported to the Kenya Health Information Systems, KHIS. So, and the National Data Warehouse has also various data use cases, and these range from program monitoring. So some programs that we monitor are the 95 cascade. We also have self-service for data use, where we have service delivery partners accessing data and making their own reports using our self-service platform. We have it being used for surveillance. We have it being used for advanced analytics, where the National Data Warehouse data is used to train models that can be used at the facility level within EMR. And then we also have the data being used for publication. So this can range from abstracts, manuscripts, program reports, slide decks, and newsletters. So here we can just see the distribution of health information systems. And people living with and coverage for people living with HIV. We know that 94% or about 1.2 million of current RT patients are seen at sites or facilities that have an EMR, that's an electronic medical record system. 97% of the above have their records actually reaching the National Data Warehouse. Now, a majority of the data within the National Data Warehouse is individual level data, as Dr. Jacob just mentioned, and there's an increased demand for patient level reporting. This has made unique identification a necessity for our project, and we'll go through the history of unique identification within the National Data Warehouse, covering each iteration of unique identifiers. So we'll start off with the first iteration of unique identifiers, and that is the client PKV, or the patient key value. So this is a concatenation of a client's sex, phonetic given and family name, and the year of birth. This code or this string was used at the facility level to duplicate records before they were transmitted to the National Data Warehouse. It was quite effective, but it lacked the ability to uniquely identify a client across facilities. The second iteration of the unique identifier was the CCC number, and this was a service number that was primarily issued to active care clients that is within the facility. The clients were required to actually migrate with the CCC number when they went to receive care at subsequent clinics. This proved to be quite successful, though there were still instances of clients going to receive care at subsequent facilities and not reporting their CCC number. So you'd have them being treated as new clients at those subsequent facilities. So this brought about the latest iteration of the unique identifier, that is an initiative of the Ministry of Health, and this is known as the unique patient identifier. So this builds upon the CCC number with the advantage that now the client has to provide some government documents to verify their identity. So the client is able to provide documents ranging from the national ID, passport, resident card, and birth certificate in the event that they are a minor. And these records are then validated by the Ministry of Health's client registry and the Kenya Civil Registry. And from there on, the client is issued an OP. And if they visit any subsequent facilities, you'll find that this identifier will be pulled from the central registry once they provide their national ID at that subsequent facility. So with this new iteration, we found that we were able to actually link records, and we now had access to duplicated records within the National Data Warehouse. But we found ourselves with a need for an MPI. And the primary reason for this was because in as much as we had these the duplicated data sets at the National Data Warehouse, we needed a way to cascade these insights back to the facility so that they can actually be adjudicated and acted upon. We also wanted to extend unique identification to active clients who we found that did not have OP, and we saw an opportunity where we could actually ramp up the issuing of OP if we had an MPI by making use of secondary attributes such as the PKV and the CCC number. So yeah, the need for an MPI brought about a consortium of partners that supported the integration of JeMPI within the national data system, the National Data Warehouse. So here we had NASCOP, which provided government oversight, guidelines, and standard operating procedures that were used for linking client records and also resolving duplicates. We also had the CDC TAP, which provided funding and gave us an opportunity to partner with JeMPI, which saw the successful integration of JeMPI within the National Data Warehouse. And then you also have JeMPI, who are the developers of JeMPI, that is the open source MPI that we've integrated to the National Data Warehouse. And you have Palladium, who, as I mentioned earlier, manage the National Data Warehouse. So next, I'm going to go into just how we integrated the JeMPI, and also look at some programmatic use cases that we have within our project and see how JeMPI fits into this. So the process of actually matching and linking records within the National Data Warehouse starts with us routinely inputting patient data into the from the National Data Warehouse into JeMPI. This is an automated process, and the data usually contains demographic information such as the patient PKV, the phonetics, the year of birth, and the address details. So this input is evaluated and it is deterministically matched for records that have UBI and automatically linked. So this matching output is then persisted within JeMPI, and it is also replicated within the National Data Warehouse, where we now have the duplication reports that are generated, and then these duplication reports are then made available to the facility EMRs via an exchange service. So we have an API that allows us to do this, and this is what brings about the actioning of or the adjudication of these duplicate records. So now let's look at the programmatic use case and see how the duplication works and where we can fit in JeMPI. So here we look at a case where we have a client with 3 records at 3 different sites, and this is a client who's receiving care at multiple sites. We can see that these records share the same UBI, and they are now actually linked. This linking can actually be broadcasted, and we can see some of the numbers that you're able to get from the National Data Warehouse. This is just looking at the duplication numbers. So we can see that among clients who are active on ART, we found that around 10,897 distinct clients were on ART in multiple facilities and appeared in a total of around 1,825 sites. This meant that on average, we had about 10,897 patients that were on ART in 2 or more facilities for a total of around 22,655 multiple interactions. So without actually UPI for the duplication, this exaggeration would have there would have been an exaggeration on patients on treatment by around 11,758. However, we also noted that about 77% of these interactions were implausible, and this is because we found that although the UPI was the same, the clients had differing demographics. So these are characteristics like age and sex. So now what we've noticed is that we're able to draw these insights at the facility level, but we were unable to cascade this to, we're able to see this at the national level, but we were unable to cascade this to the facility level. And so this is where we actually now find use for the MPI. So the MPI provides an API where we can safely cascade these linked data back to the facility. And that is actually what we set out to do. And you'll find that once this is provided at the facility, they are able to generate actually or render a report that looks like this. This is an example of one of the EMRs that is actually connected to our National Data Warehouse and MPI, and this is Kenya EMR. So they're able to actually get a deduplicated data set that has details about the sites that this client is receiving treatment on, and they're able to render it with even more information at the facility level. From here now, they can be able to adjudicate this particular record, contact the client even, and figure out the reason as to why they have duplicate records. And then following an MOH issued standard operating procedure, they can go on to resolve these duplicates. On top of this, we were still able to come up with extra use cases. And for this, we were able to, and these were in the form of notifications. So in our implementation, we saw that there are still some active clients, that is clients active on treatment, who did not have UBI, but they still had the secondary attributes. So we still made use of JeMPI to actually match these records to linked records, and in this way actually hasten the issuance of UBI. We're also able to use the MPI for validations, actually national level validations on linked records. So this is where we can actually look at the linked records and see if there is any conflicts within the demographics. And once we find this, we are able to generate notifications, which can be cascaded back to the facility and resolved. From here, I would like to invite Natasha, who will give us again an oversight on JeMPI. Thank you.
Yes, thanks, Paul. And as Natasha shares her screen, I think you've mentioned some very important concepts. One, the idea that you have individual level data to deduplicate in the first place. So I think that's an important one. And then the second thing, just to highlight that, is the API that then sends back feedback to facilities on EMR sites And maybe we'll explore this further maybe towards the end when we come to the Q&A session. Natasha, I see your screen is up, so you can go ahead and do the second presentation.
Thank you, Dr. Jacob, and good day to everyone. I am Natasha Maestri from JeMPI Health Systems, and together with Dr. Chris Siebrechts, founder and CEO of JeMPI, and William Hayes, will be presenting on the MPI system, JeMPI, that we have implemented in this project. So let's take a look at the origin of the system and why did we create something that later became known as JeMPI? We were tasked to evaluate open source MPIs. However, we had no reference to compare these open source systems to. To address this, we used batch processing tools like the Python record linkage package, FastLink, and Splink as a reference. Eventually, to streamline and enhance this process, we transformed the functionality of these tools into a service, enabling more effective benchmarking and assessment. And it is this service that we now call JeMPI. Initially, JeMPI focused exclusively on batch processing CSV files and did not have a user interface. However, over time, we extended JeMPI to support transactional processing and added a user interface for adjudication. What are the different processing modes of JeMPI? Firstly, we have batch processing, which we refer to as the asynchronous mode. Async processing leverages a Kafka message broker for communication. And secondly, we have transactional processing, which we refer to as the synchronous mode. And with synchronous processing, we rely on RESTful interfaces for interaction. Asynchronous and synchronous processing impose distinct demands on the adjudication process. The first distinct demand is that in asynchronous processing, adjudicators operate with a different context availability compared to synchronous processing. Another distinct demand is that synchronous adjudication events are resolved in real time as they occur. So in other words, the system remains stable in real time. Now, JeMPI was initially designed to support asynchronous processing, enabling the import of large data sets. So for example, hundreds of thousands of records followed by adjudication. It's important to note that client registries vary in how they store adjudication events. This influences the type of adjudication process that can be applied. So in your data warehouse scenarios, we typically use asynchronous adjudication, whereas with central data repositories of health records, we favor synchronous adjudication. The key point here or takeaway is that client registries are often limited to synchronous processing due to the way adjudication is actually implemented. Also, in addition, client registries also vary in their linking strategies. Some link incoming interaction records directly to each other, while others link each interaction to a golden or master record. When we link interactions directly to each other, synchronous adjudication is essential for managing the complexity of the links. Conversely, linking interactions to a golden or master record helps keep asynchronous adjudication manageable and efficient. For JeMPI, we adopted the strategy where interactions are linked exclusively to a golden or master record. This strategy allows JeMPI to efficiently handle both synchronous and asynchronous linking and adjudication. This approach also enables adjudication to occur in either synchronous or asynchronous modes, providing greater flexibility and scalability. For this project, we use the async linking and adjudication capabilities of JeMPI. In this slide, we introduce the base standalone JeMPI infrastructure. JeMPI is built on a collection of microservices, and with this modular design, we ensure flexibility and scalability while addressing the core requirements of the system. The purple blocks on the left represent the source of patient records. This source can be synchronous requests from EMRs. Now, this is not the Kenya use case, or the source can be CSV files of periodic data from facilities, or as in the case of Kenya, and this use case, from a data warehouse. The large yellow block represents the base standalone JeMPI infrastructure. Here we have an MPI database, which is the dark blue block. a general database for notifications, the light blue block, a Kafka broker for asynchronous messaging, which is depicted by the gray block, and a bunch of microservices coded in Java, which are the green blocks. The microservices have the following. There are two source components that handle the synchronous and asynchronous input and output interfaces. The ETL component can be used for data transformation, like transforming incoming biometric templates to subject IDs, or just data cleaning as required by the system. The controller component routes incoming transactions to the machine learning component, which is the EM block, and to the linker component for linking. The controller also collects asynchronous responses that it saves to a database for reporting purposes. And in addition, it also collects notifications that it saves to a database that can be later retrieved via the REST API. An unsupervised machine learning algorithm, the EM block, implements the expected maximization algorithm that computes the quality and uniqueness properties of the fields used in probabilistic linking. And then finally, the linking component implements the classic deterministic and probabilistic linking algorithms. So just to recap the points that I've made about linking strategies and how adjudication is affected. An MPI can be visualized as a system of patient-centric graphs. There are many schema options for structuring these graphs, but to illustrate the points I want to make, we have two schemas in this slide. The diagram on the left shows the grouping, or linking if you'll have it, of a patient's encounters in a single graph. And the diagram on the right demonstrates linking encounters directly to a golden or master record. Other graph schemas are also possible, but the main focus here is on the async nature of linking and adjudication, both critical for this project. The schema in the diagram on the left suits synchronous processing, where immediate adjudication resolves cases like the E5 to E1 link efficiently. JeMPI, however, uses the schema depicted on the right. Instead of adjudicating the links, it adjudicates at the encounter level, leveraging the graph's context during adjudication to relink E5. This approach aligns well with asynchronous linking and adjudication. That's the end of my presentation. For now, I'll hand over to Chris to conclude JeMPI's presentation. Chris?
Thanks very much, Paul and Natasha, for the presentation to date. I've just got one slide that I'm going to present just to contextualize the work that we've done on the development of JeMPI within the context of the health digital public infrastructure that is currently being developed by WHO and others. We thought it was really important to make sure that that whatever we are developing adheres to this emerging framework. And we've tried to depict it here in this diagram where we have the health DPI architecture framework on the left-hand side, and then the structure of JeMPI within its context on the right-hand side. So what we see on the left-hand side of the diagram is the layered architecture of the foundational DPI, and above that, the DPI for health that has been developed by the WHO. And in this framework, JeMPI fits into the registry layer of health DPI, either as a standalone component or alternatively combined with other components, including the OpenHIM, which is another open source software developed by JeMPI as an interoperability layer, and bundled together into what we call the OpenHIM platform that integrates these components. So that becomes an instantiation of the digital public infrastructure for health layer, and also connects, as we heard from previous speakers, JeMPI connects to the digital ID component, which is located down in the foundational DPI layer by using the UPI citizen ID that has been developed and is being used in Kenya. So we can see how the the Health Digital Public Infrastructure Framework is being implemented here by having the master patient index, reusing the digital identity from the foundational DPI service. And then similarly, we heard that the results of the patient matching and linking are then passed up to the electronic health record, which appears in the functional applications for health layer above that. And that happens through the interoperability layer, which is provided by the OpenHIM platform and its Kafka messaging service. So this is, I think, an important part of the way that we are developing at this stage to try and integrate whatever we are doing and to create reusable the principles of the 8 health DPI, which is to create reusable building blocks which are interoperable and use open source software in order to promote reuse and reuse of these components. So we just wanted to make that point as well. Thanks. Back to Dr. Jacob.
Yeah, thank you so much, Chris. Thanks, Natasha and Paul, for the excellent presentation. This provides both the programmatic side of this solution and the problem that it was coming in to solve, and then the technology pieces that make the whole. I wanted to just maybe go back to the discussion about Kenya's journey from using probabilistic matching through PKV to now using a national identity system. And I wanted to maybe ask Dr. Lily, can you please just maybe provide a brief summary of how the Ministry of Health is collaborating with the civil registry to verify details that a client is submitting to the is providing to the facilities for the purposes of identity verification and identity management. Dr. Lily, you can maybe respond to that question.
Thank you. Kindly confirm you can hear me.
Yes, I can hear you clearly.
Yeah, thank you for that question. I think the journey to unique patient identifier for the country has been long and it's quite comprehensive. We started, especially for the HIV clients, so I will give my context from the HIV clients, although I do want to recognize that the country is now moving towards unique patient identifier across the health system. So we started along back with a unique identifier that we were calling the CCC number, which was a comprehensive care clinic number. This was an alphanumeric number that was generated, had been, of course, envisioned to be unique, but of course, given that the numbers were assigned at facility level, then we couldn't be able to assure that this number is unique, especially if clients moved facilities or if clients deliberately moved or deliberately wanted to switch facilities for reasons that are, I think, known to us. So 2 years ago, I think the country started engaging in conversations around having a more robust, unique patient identifier. And one of the things that we did is that we had now this agenda being pushed from, or rather being moved from a larger ministry perspective, unlike the CCC number that was a HIV specific number. So at that point, we had the ministry issue a circular or a regulation, which is usually really the starting point for ensuring that policies are taken up by facilities and, of course, the counties at large. So we had an issuance of a circular where healthcare workers were advised that going forward, we are going to be utilizing a unique patient identifier. One of the things that this circular did is that it ensured that there was a collaboration between the service provider and the client registry to ensure that there was a way of ascertaining that indeed the patient was being given a unique number. So one of the things that was in that circular, the requirements was that the unique patient identifier would be based on a national ID, which everybody in this country receives at the age of 18. And for the people who are below 18 years, then they were expected to use a birth certificate, which is also another legal document that is issued at birth. And of course, then we do have alien IDs for the non-Kenyans. So with these requirements of legal documents which you needed to present in the facility, what happened is that when as the clients come to clinics, then they would come with the legal documents, and then the service provider would then enter the number in the system, query the system directly. It was real time to the client registry to ensure that one, this client is not registered, and also to ensure that this number truly does exist. And if the number was found to exist and had not been issued a unique patient identifier, then that number would be assigned to, to that legal document. And so we were able to follow up over a period of time. So of course the HIV program took it up. We were able to follow up and confirm that a total of 95% of all our PLHIV on treatment were able to be assigned a unique patient identifier. Yes. Back to you, Jacob.
Thank you, Lily, for that response. And yes, so Kenya's scoop is derived from the national issued IDs. But what, in your opinion, do you think is the reason why a patient would seek care in multiple facilities? What has your experience been why patients do this?
So there are several reasons that clients would seek services in multiple facilities. I think the ones that come off the top of my head, one is we have been able to identify that when clients are tested and they test HIV positive, usually they will undertake multiple tests. Some will be self-test, some will be tests at facility. They will undertake multiple tests before they can actually, finally the diagnosis can sink in. And so if a client is accessing testing in multiple facilities in a bid to confirm whether they are indeed positive, they will always show up at facilities as though they are testing for the first time. We were actually able to identify this when we were conducting the recency testing, because what we used to do is that when a client tests positive, then we would consent them to enroll for HIV recent infection testing. And so when you now then start having that conversation is when they would confess that they have indeed been positive, and they were just taking their time to find out whether they are positive. Another reason that we have found is we do have these patients who are interrupting treatment for various reasons. I think one of the commonest reasons in this country is patients who seek alternative medicines. So that could be herbal medicines, but we also have another medicine that is very common in this country. It's called prayers. So clients will seek prayers from pastors that have claimed that they are healing clients. And so clients then some of the clients have done a routine antibody test that has tested negative, and so they have disengaged treatment. And once they start now getting sickly, they will come back to treatment. What will happen is that when this client is re-engaging treatment, they do not want to go back to the facility where they were seeking earlier treatment. And so they will show up as a different individual. And so with the unique patient identifier, you're able to actually see this client has actually been on treatment prior to this specific service. Of course, also for our KP patients, we know that in this country, key population activities are criminalized. And of course, they are also accompanied by stigma and discrimination. And therefore, some clients do not want to show up in a facility with their true identity. Of course, there are many other reasons, like when we used to give incentives. So clients used to go to multiple facilities because maybe there's a facility that is giving flour, there's another one that is giving maize. And so clients would register in multiple facilities so that then they are able to access the multiple services and benefits. Thank you, and back to you, Jacob.
Lily, thank you. That was very, very comprehensive, and I really like the social aspect that we have to always consider when implementing a public health program. There's so many social dynamics that make these solutions then so important to address those challenges with data. So I'll just shift to more of a technology focused question and answer session, and then maybe Lily will come back to you later with a bit of a question about why duplicates are not good for public health programming, and we can come back to that if we have time. But now I'll ask maybe this question to Koske about what custom workflows did you consider in the implementation of this integration of MPI in the National Data Warehouse? Koske.
Yeah, thank you, Dr. Jacob. So I think once you have your National Data Warehouse, there is need to achieve deduplication. I think that is a key component in any data warehouse that you're working on. So when we were considering JeMPI as our MPI, first of all, we needed a centralized store where we can have an incremental build of our MPI, such that over time we're able to build our clients in one central repository. And of course, with the help of the unique patient identifier, it has really assisted that, because that was the key thing. We wanted to be able to link patients who have the similar UPI, and that is the only way we can ensure that the clients are linked, and any deduplication is done based on that. So the new peers has been highlighted is means that the client has been verified at the facility, so it can authoritatively allow us to do the linkage. Then the other thing was, once you don't have the UP, what else can we able to link? We should be able to link with other identifiers, and that can also assist during the deduplication processes. So I think it's good to highlight that an MPI workflow also, the EMR plays a critical role. As has been highlighted, there is need to be a bidirectional communication between your warehouse and the EMR facility. So the EMR facilities, the EMR of the facility is able to pull in the duplication reports and do the process of adjudication at the facility as per the MOH guidelines, which states that patient record linking should be done at the facility where the patient's identity can be verified. So I think also our workflow also involves those reports. So I think that also contributes to our National Data Warehouse data quality, where data quality is part of the National Data Warehouse processes, and those reports are availed at the facility and where action can be done. So ideally, that is what we were looking for in an MPI. And those are the key components that we were looking for and ensured that had been implemented through the JeMPI. Over.
Thank you, Koski. I think you bring two aspects that I think are very important. It is not only for deduplication that an MPI would be useful, but also to send back feedback to facilities so that they can act on data quality gaps that are identified at the National Data Warehouse level. So that's an important part, while making sure that at the data warehouse, the records remain anonymous. Now, I want to shift a little bit more to the tool that has been used for patient identity management. That's the JeMPI tool. And this is to Natasha or Paul. How does JeMPI ensure seamless integration with diverse information systems? Because other countries may need this solution, other implementers. And what were the most significant challenges encountered during integration within the Kenya JMIS project?
Thanks, Dr. Jacob. Maybe I'll take the first part and then Paul can add his perspective. So JeMPI ensures integration by adhering to open standards and offering configurable APIs. This and the fact that it's very easy to adapt JeMPI to fit the problem helps in realizing interoperability with various health information systems. So like in our case, the data warehouse. With regards to our primary challenge was aligning data models and ensuring consistent handling of pseudonymized records across systems in the absence of the UP or unique patients identifier. We also had to manage the deduplication of data that was sourced from multiple facilities with varying data quality. So to help us address these challenges, we extended the classic linking functionality, whether this is deterministic or probabilistic, to get the healthcare worker to do the linking using the match and validate functionality that Paul had mentioned earlier in one of his slides. Thank you. Over.
Yes, I don't know if Paul or Denson, you have anything to answer, to add to that?
Yes. Thank you, Dr. Jacob. I can maybe add on to that. Yeah, one issue that I came to notice that was a big challenge at the beginning was that we found that JeMPI was difficult to run in resource settings that were a bit low, and this may be something that will also might affect other countries that would want to implement such an MPI. And working closely with the development team at JeMPI, we were able to come up with different deployment modes. So you find that the deployment mode within JeMPI is actually quite configurable. So if you want to work with a low resource setting, but you have time to do the matching, you can deploy it in a low resource requirements. And if you want to be highly productive, you want to do a lot of matches within the shortest amount possible, and resources are not a limiting factor, you're able to run the platform in a cluster mode using multiple instances. So yeah, that is something that we found a bit of a challenge to start with. We were able to work on it and maybe have an MPI platform that can actually be deployed by countries that are dealing with patient numbers of any level. Yes, sir. Thank you, Dr. Jacob.
Okay, thank you. I think I'll just go on to the last question, which William can take. How is linking useful if only pseudonymized names are being used?
Yeah, thank you, Dr. Jacob. So pseudonymized, the source of the records we had to link, it basically came from a data warehouse, and there was historical data in there, and by its very nature, the names and things like this, it's all pseudonymized, so in our cases, it's like phonetic encoding of the names. So now we come, like immediate accuracy. It's not possible to get immediate accuracy with pseudonymized values because you can't link it deterministically or probabilistically. Paul mentioned and Dr. Lilly, the whole role of the UPI that plays such a fundamental role in this thing, but it's not always available. So we had to shift focus a bit. Instead of going for immediate accuracy, okay, what we needed to go for was build a system that just improves over time. So as time goes along, the system gets better and better and better. Okay, so this is where we can use pseudonymized values to improve the information that goes back to the EMRs, to help the process. So it is really like that. We had to add functionality where we remove the linking from like a computer doing the linking to an actual healthcare worker doing the linking. That and it was the functionality that we added that helped the healthcare worker do the final linking, for those cases. So you can't link with it, but it does provide and it helps you detect potential errors. And it's just this continuous improvement, of the system. That is what ensures a better continuity of care as time progresses. Thank you.
Okay, thank you, William, for that question. I think I'll maybe take a pause before I go back to Dr. Lilly. The question I wanted to understand about the challenge that duplicates pose to the health system. I want to just give it just a bit of an open forum where we can take any questions from the audience. or any comments from any of the panelists. I can just give a couple of seconds for that. If there's any question from the plenary team, we can just raise your hand so that you can ask the question before I give a chance to Dr. Lily to crown it all with maybe a comment on the question that I have raised. Okay, as we wait for any hand to be raised, maybe back to you, Dr. Lily. Maybe you can just comment about the challenges posed by duplicates, because really that is where the value of this solution then becomes key. Dr. Lily, the final word.
Yes, thank you. And thank you for that question. I think it's a very important question. First of all, it's a legal requirement that the program is maintaining an accurate record of patients that are living with HIV in this country and beyond. Even in other service delivery points, we are expected by a legal requirement to be maintaining accurate records of the patients that we see. So one of the things that we have observed with duplicate records is that is really an overestimation of our, just as a basic, like our current on treatment or the people that we test. The danger that this poses is that when we are doing our forecasting and quantification, is that we are basically doing all the planning with the wrong numbers. And so this is going to cause us to quantify for more, say, test kits, because we think we are testing a lot more people than we do. We are bringing in more quantities for ARVs and more quantities for viral load testing and the other commodities that are utilized within the HIV programming. And so midway into the implementation, we realize we have overstocked our quantities, and we are starting to experience wastage and expiries of these commodities. So that is really one of them. Of course, the other planning cycles are also affected. In terms of service delivery, we are planning for people that either don't exist. And so this really leads to a lot of resource wastages and inefficiencies within the health system. Another problem we have seen is that, especially for the patients who are interrupting treatment, most of these patients, if they come back as a new client, there are two dangers that are going to be posed. One, you're going to initiate this client on a routine treatment, thinking that this is a patient who has been newly diagnosed. One, you overestimate the people that have been diagnosed. And two, you start patients on a wrong regimen. Perhaps this is a patient who has advanced HIV disease, you miss it. This is a patient who's probably already starting to experience resistance, given that they have been on treatment. You also miss that. And so you continue then to mismanage the client. And that, of course, has repercussions and ripple effects to the larger HIV population, where you're continuing to promote, say, drug resistance, or a patient is going to lose their life because they have advanced HIV disease, which you miss because of the making such decisions around a patient you think has been is a new patient in the system. Of course, the other big problem, especially with duplicates, is that our HIV estimates, which, for example, I'd like to give an example of, say, for example, the HIV estimates of 2023. We used data from, we usually use program data as inputs into the HIV estimates models. So if we are utilizing wrong numbers, then we keep, getting HIV estimates that are misaligned with the program data. And of course, at one point in time, we are having maybe counties are complaining that the HIV estimates are not aligned to their program, but it's because we are inputting wrong data. So one of the things that we have seen in the recent years is that since we have shifted from utilizing, say, KHIS data, and we have started to now triangulate our treatment numbers with what is in the National Data Warehouse, which has deduplicated those records, is we are starting to now see that our estimates are starting to align, and we are seeing less and less complaints, both at the national and the county level, because then the estimates are sort of like speaking to what we already know as a program. Thank you.
Thank you, Dr. Lily, for that. There are two questions that we can quickly take from the audience. I see a question from Telenam that are the benefits of this linkage visible to other program areas? I think, Paul, you can take that. And then the second thing is about cases of patients who present without government issues like this. Natasha, can you take that?
Yes, thank you.
Yeah, Paul, you can start with the first question. Then that will be
yes,
it.
okay.
Yeah.
Yes, thank you, Dr. Jacob. I think as Dr. Lily has mentioned, the use of UPI was actually just introduced 2 years ago, and it was primarily used as a follow-up to the CCC number. So we found that it was just used mostly on patients who are within the HIV program, but it has already been scaled to clients who are in, let's say, HTS, that is the testing programs, and we're also on PrEP programs. The ministry has also decided that the issue of UPI is not just limited to the HIV programs. So you actually have it now being used across the entire facility. And with this, we expect to have this linkage spread to not just the HIV program. So we expect it to maybe move on to maternal health or any other programs that a facility would provide. And the use case or the process would still be the same. That is, they would still present their government issued documents and from there on receive their UPI. So yeah, to answer that, within the Palladium National Data Warehouse, that one has been primarily for HIV data. But as we take in more as we take in more programs and as the Ministry of Health scales up UPI, we definitely expect this linkage to be available for these other programs. Thank you, Dr. Jacob. Natasha, maybe you can answer the second question.
Thanks, Paul. Okay, William?
Sorry. I can also try and answer it. Let me just recap the question. So the edge cases, it's like the edge cases where patients present without a government issued ID. Okay, so for we initially started with like deterministic on the pseudonymized data. With there's also gender and date of birth, I think, and things like this, and later on we added the CCC number. And then later the UP, and that just became a pure deterministic link on the UP. So then we said, okay, like let's assume the UP is missing. So in other words, the only link rule that we've got is link deterministically on the UP. If that thing is missing for whatever reason, then we can't link. That's when the functionality we had then was, okay, if you can't link on any field, any demographic field that you've got available, so your gender, your date of birth, including your pseudonymized data, like the phonetic encodings of your name. You don't link on it, so do like a pseudo link, and that information goes down to the clinic. The clinic then, the healthcare worker will then solicit like either if the patient hasn't got an UPI, it will like start that process, or if UPI hasn't been issued, or if UPI has been issued, it will then collect it and resubmit that form. So we don't link on. This is the addition that we have to add to JeMPI. We don't link if we don't have information to link. We actually just we pass it back to the data warehouse and back to the clinician. That will and that step can take a month, because it's only in a month's time when the patient comes to the facility again. That's where you pick up that issue. And that's what I meant by it's not immediate accuracy. We don't go for immediate accuracy. Rather, what we're going for is we have to get a system that improves over time. Like it's really that way. So it's a different view of the functionality of an MPI. There's nothing immediate in this thing, simply because we do not have the data to be immediate. But we can definitely improve it. And over time, continuity of care, it's the constant thing is time. It's over time you provide continuity of care. So over time, the MPI improves. I know, Paul, like maybe you want to add more?
Yeah. Maybe I'll just provide some short context. I think that is good from the perspective of the warehouse. But one thing that is important to note is even at the facility level, even if they don't present these government documents, they will still receive care. That is something that is not going to be denied to them. And actually notice that provided that they are given counseling and advice on the importance of linking, a lot of them will actually be okay with maybe coming on the subsequent visit. They will actually provide the government document that will allow these records to be linked. So from the context of the facility, they will still receive care. It's only that their records will not be linked until they have been verified using their government documents. Thank you. Maybe I don't know if Koski has something to say.
Yeah, so I think there was a question around support for other programs. I think the NDW is a robust and scalable design. It's built around the client, meaning that we are able to support all other programs, not necessarily HIV. So any other program is be able to be supported. And of course, once the NDW is built around the client, then definitely we're able to utilize the MPI in any other use case that may arise. So I think it's good to highlight that. Thank you.
Yeah, thank you so much. We are just about at the top of the hour. We have had two presentations that talk about the data warehouse, the integration of MPI within the national data warehouse. We've gone through the technology that's certainly powering the patient identity management solution, how the matching, the duplication is done at the warehouse level. We have also heard how the insights from the duplication process is sent back to the facilities for action, and the value of this and impact of this to the program. I think it's been a very insightful session. We have come to the top of the hour. We thank you so much for making time to attend the session, and also to the presenters and panelists for the insightful discussions from Kenya's experience integrating MPI's JeMPI specifically to Kenya's National Data Warehouse. Thank you so much, and see you again next time. Bye.